Okay, so since we are at 12:15, I will go ahead and get started and we'll let others trickle in. I'm Noelle Spears. I think I know everyone online here, work in the emergency department clinically, vice chair of education. And we have a wonderful talk today as part of our faculty development, our PEAC series. We decided to focus on the learning environment. So I'm really glad Dr. Reese is here as well, and took two of our most beloved and educators that have been celebrated by students as being top educators to help us learn what their secret sauce is. So today we have Drs. Felker and Dr. Cummings, and I'll give a little intro. But Dr. Kirsten Rose Felker is a pediatric cardiologist who specializes in heart failure and transplant with a special interest in cardiac care of childhood cancer survivors. She completed fellowship training in both pediatric cardiology and pediatric heart failure and transplant at Emory, residency at Lurie Children's, so did I, and med school at George Washington University. She's incredibly interested in training the next generation of pediatricians and cardiologists and is an associate program director in the Pediatric Cardiology Fellowship and program director of our Heart Failure and Transplant Fellowship. She is the mom of two great kids and credits her sanity to her husband, Jim, an oncologist in the Division of Pediatrics, who I think has also joined us today, which is great. Dr. Erin Cummings is an assistant professor of pediatrics at the School of Medicine and in our Division of Pediatric Hospital Medicine. She earned her Bachelor of Science from Brown and completed med school right here at Pitt. She completed her residency and chief residency here, and we were lucky that she stayed on our PHM division. And she's been a fantastic advocate for medical education, especially coming from Pitt Med. She has clinical and research interest in interprofessional education and resident medical education, and she currently serves as one of the clinical skills preceptor and code at the new Pitt Med Three Rivers curriculum and co-directs the Introduction to Clinical Medicine course. Erin and Kirsten, thank you so much, and I'll let you take it away.
Well, thank you so much for that really nice introduction, and thanks especially for the opportunity to do this. I think when Erin and I first met, I was very, very excited to get a chance to know Erin doing this. And I think Erin may know the secret sauce a little bit more than me. But when we set out to do this, we thought, well, how are we going to structure this talk? And Erin, you can go ahead and advance this slide. So the first thought we had was really, what do our learners think? What do they want in the learning environment, and what can we be doing better for them? And so that'll be the first part of our talk today. That sort of jump-started us into thinking about self-directed learning and some theories of adult education that we can use in the clinical learning environment. And then last is really just pearls. How do we apply this in our really busy clinical setting when we have patient care tasks, documentation, and teaching all at one time? So to start out, what is it that we want? We sent an anonymous voluntary short survey to our UPMC pediatric residents with the approval of the pediatric leadership and to the pediatric cardiology fellows last month. And we asked 4 relatively simple questions, but questions that really structure the rest of this talk. The first was, how far into your current training role are you? What barriers to learning have you encountered in the clinical setting? What factors have fostered a good learning environment, and what would you recommend to educators if you were going to give them one piece of key advice? And we were really excited to have 41 responses. And the responses really, they reflected the population of the people that we sent the surveys to. We had 37 residents respond to the survey and 4 pediatric cardiology fellows. And I think this represents a really nice breakdown in what we were hoping to see, is that about 1/3 of our fellows were in the final 12 months of their training, which you can see in green. About 1/3 were in their initial 12 months, and then the rest were in between. So we got a nice sample of people throughout the learning continuum. And I think this slide for me was really the most informative in how can we do better? And what is it that our trainees really expect from us? We asked them to provide multiple choice answers. They could select up to 3 of these. Which of the following barriers have you encountered in the clinical education scenario or environment? We had 36 respondents that suggested excessive patient care that prohibits structured learning or leads to burnout. We had 20 that responded that lack of feedback or personal time with teachers was holding them back. Some saying there was lack of case-based teaching or bedside teaching, and then fewer that talked about excessive supervision, lack of feedback, and lack of clear expectations. I think if we surveyed educators, which we didn't do, I think we would have found the majority of educators might respond in a similar way, that excessive patient care and tasks around patient care are what seem like a big barrier to teaching. And there are some things outside of our control, but I think what we sought to spend this time talking about is how do we make that little time we have count? And I think for me, the lack of feedback or personal time with teachers shows that our learners really want to be noticed. They want specific and structured feedback, and they want it to be delivered in a way that they can relate to. Things that they felt like were helpful in the learning environment. I think we were not surprised much by this. Our learners want balanced time to work and promote personal well-being. They want to feel safe to admit uncertainty or ask clarifying questions. They want clear expectations and objectives early on. They want trust from educators so that they can practice autonomy and practice clinical decision-making. But they also want appropriate supervision. And I think this balanced time to work, I thought, well, does this mean that the majority of learning is happening on slow clinical rotations or at times of the year where we don't have a lot of patients on our service or in clinic? And I think that's actually quite the opposite. I think what it is that we can do is just learn to promote a balance in structuring the time that we have to teach and the tasks that we all need to do. And this really is we don't have time to take out all of the really great comments that our learners provided in the open section feedback, but there's some common themes that we found amongst these free text responses. And I think that our learners said they want relevant, quick teaching points after clinical encounters. They want objectives and roles made clear. And they want focused teaching time, but also allowance to complete tasks. They're looking for a culture of explanation and open discussion around decision-making that makes them feel comfortable asking us questions and participating in decision-making. And they want us to pay attention. When I stratified the results by the fellows and the trainees, I thought it was really interesting that the type of trainee really had some themes that fell out as well. I think resident themes highlighted a desire for goal setting and feedback. And our fellow respondents tend to focus more on the desire for autonomy and creating safe boundaries that they can deliver care. And even amongst in those individual groups, I think as time into their training increased, the desire for opportunities for growth and decision-making increased as well. And so this probably brings me to one of the most, I think this is probably the thing that I learned most from as I looked at these responses and thought about how we might structure this talk. And I think this was that there was a response from a initial 12-month resident that said residents are not secretaries, we're learners, sometimes taking tasks off our hands like a discharge summary or allowing more time for learning or the ability to ask questions or thought-provoking processes that have been lingering goes a long way. And I think initially I felt like this was challenged me a little bit in that I think it's difficult sometimes for our learners to realize that we feel a lot like the person in the picture that that we are so task bound as educators that it sometimes feels like we can't take additional tasks off someone's hands. And so I think this is really helpful, I think, in having us sort of reframe how we're going about education and having our learners understand. Because I do think it comes a lot more naturally to some learners, the concepts of adult learning theory, whereas some really need some structure and explanation around that. And Erin, I'll hand it over to you for this part.
Perfect. Yeah, absolutely. So that's our transition into part 2, which is a tiny bit more background. And then part 3 has some more kind of brainstorming together and interactive pieces. But part 2 just prompted us to think about how we can encourage our learners to be self-directed when we have so much else to do, being the crux of that question. So how are we preparing learners for this learning environment? And at the outset of training, we can provide trainees with some guiding principles of adult learning theory. We can explain to our trainees that time management is one of the most important lessons of medical training, and tasks are part of any career in medicine. And anyone can pick from the menu of different things: prior auths, insurance denials, communication of care plans, documentation. Those things are not resident tasks or fellow tasks. Those are not going away. And then thinking back, as Kirsten mentioned, the principles of adult learning. One of our sources on this comes from Malcolm Knowles, an educational theorist who wrote The Modern Practice of Adult Education in 1970, and really solidified this adult learner being autonomous, free, and growth-oriented. And the contrast between pedagogy, which is what we're used to from our early years, the art and science of helping children learn. That's a very teacher-centered approach, and then structure is guiding the learning process, and students are fully dependent on the teacher for knowledge and guidance, versus andragogy, which is the term for the art and science of helping adults learn. Learner-centered approach where adults are taking responsibility for their own learning and are motivated by practical applications of knowledge to real-life situations. Happy to say too that just from the Pitt Med perspective, I think it's exciting that we've been folding in tons more self-directed learning, but in terms of kind of the official dichotomy or what you'll find in the literature, just a little bit more contrast between this teacher-directed learning, which may certainly include college and up to medical school, might be more formal, authority-oriented. The planning and the goal setting is by the teacher. There's lots of assigned readings, and then the teacher is really doing the evaluations. And then we want to get, including med school, sort of to help be on this continuum of the self-directed learning, which really comes into effect in residency and fellowship. And we all know that it's a lifelong process for us. So that can be more informal. It's mutually respectful. There's participative decision-making about what the planning looks like. It's learner-centered mutual assessment. And it has task or problem-centered learning activities rather than assigned readings. And then evaluation and feedback is by mutual assessment of this collected evidence. So how do we think about this? So Knowles tells us that individuals can take the initiative with or without the help of others in diagnosing their learning needs, formulating their learning goals, identifying their resources for learning, choosing their strategies, and evaluating their outcomes, which sounds very much like the goal of what we want our learning environment to be for our trainees. So with our thinking about just the course of our ever-expanding medical knowledge, it is no longer reasonable to define the purpose of education as simply transmitting and memorizing what is known. And instead, we want the purpose to be to develop the skills of inquiry. And so what is part of why we're there? We're there to foster self-direction and provide assistance in locating those resources. So what might this look like? Again, nothing in this presentation is exhaustive. There are many ways to make a wonderful learning environment, but especially thinking about our different specialists that are here, whether cardiology, hospital medicine, or otherwise. When you're thinking of working with our pediatrics residents, we find it really helpful to kind of think about familiarize yourself with the ABP list of topics in your specialty as you're used to working with learners. And here's the cardiology example right here. And then, as we said, provide assistance in locating resources. So when you have some time, put together a list of resources to provide to your trainees prior to the start of their clinical rotation with you. And this really allows self-paced learning. So there's a couple of ones that both Kirsten and I really go to. There's you can maybe tell who's who, but heartuniversity.org, the AAP PediaLink training curricula is wonderful. Both of us have leaned on MedEd portal a lot, and then I frequently recommend Peds in Review articles to my learners about different diagnoses. And not only resources about the medical information that's going on, we really feel that written expectations, location, clinic start time, note writing, rotation expectations, etc., are really, really helpful. And then there can be links or attachments with these guideline papers. Perfect. All right, I'll hand it back over to Kirsten for this next bit. I can advance the slide one more time.
Okay, so I think a lot of us agree that in theory, these are great principles, and in practice, sometimes we feel a little bit like this, that teaching is just something that we don't feel like we have time for. So how do we apply this in a really busy clinical encounter? We divided this a little bit by outpatient and inpatient. I think that just to start, I'm interested to hear anyone from the audience if they have thoughts on this. Here's two clinical scenarios that you might encounter in an outpatient clinic. It's a busy morning. You have multiple slots overbooked. Patients are getting rooms slowly, and you have a skilled resident learner. How do you begin that session? What are your strategies for supporting your learner? What are your strategies for balancing your time? And then I'll read the bottom, and then maybe I would be happy to take questions or suggestions from the audience. How do we contrast that with the afternoon? Now we have a first day PEDS PGY1 who hasn't rotated in this specialty. How do we begin clinic there? What are our strategies for supporting our learner? And how do we balance our time? Feel free to raise a hand. Andy, how would you address these two learners?
Yeah, I think the skilled learner in the first session, what I want to do first is just take that 5 minutes and get a sense of what they're there for. And that's kind of what their goal for that session may be. And I may try to help them craft that a little bit to say, if it's too broad, to shrink it down to something we can do in the day. And then I'll frequently ask them also, what do you want me to watch? Because I think I want them to be driving the agenda. Like, do you want me to watch when I come into the room to follow up on your visit, how accurate your exam was, how well you counseled the family, how you worked through the technical aspects of the visit. And then when I know I'm overbooked, I just am honest with it. I'm like, hey, we have a really busy clinic today. So this is going to be one of those days where we're really going to have to be nimble to get a lot of learning done. So let's think about how we're going to do that. Maybe I'm going to have you see a couple of patients at a time while I chew through others. And we're going to use our support staff, our nursing staff in that optimally. And, we're going to do that as intentionally as we can, because I want to teach them those skills too. How do you confront that busy clinic day?
Yeah, that's really great. I see Dr. Hoffman had her hand raised too.
Hi there. Sorry, I was clicking all the buttons. Yeah, I love these questions. So I think that, like, in both cases, if whether they're skilled or not skilled yet in their trajectory, I think orienting them to where they are is really important in terms of flow, what to expect, how things happen, who to go to for what, where are things in the clinic, because that just puts them on such a better footing, just in terms of, knowing the environment and how to work through it, because every clinic is set up completely differently, in terms of what you can find and where. The other things are, I think for both, asking what they're hoping to get out of the experience and trying to see if I can focus some of what I'm putting on their plate in those areas in particular, whether it's that they really want to get very good at listening to murmurs. So I'll kind of prioritize some of the people that I know have great murmurs. Or if they really want to get good at anticipatory guidance, then I know that I might send them in to do anticipatory guidance for multiple patients. And then I love like sort of running a list in terms of, when I'm looking at my list of patients, I'm prioritizing in my head and talking through, what I'm going to do, how I'm going to do it, what I'm going to need. And having that sort of talk out loud with that person at the beginning of clinic also can prepare them for success. And dividing and conquering, and telling them, what they, expectations are, and giving them some of the bits of key piece of information that will really help them, in terms of, this family, child has, nonverbal autism, but he really loves cars. So focus on that, and he'll love you and let you listen to him all day long. Sharing that, like bringing them into your inner circle with your patients, can help with a sense of belonging, and also help them have a great experience along with your patients as well. And then I do remember there were times when I would have attendings actually knock on the door of the next patient and introduce me and let them know, like, I'm going to be in later. This is so and so. They're working with me today. They're great. Sort of leveling me up as a learner and making me really a part of that team. And that also made the experience feel better, because it wasn't when is the sort of the specialist coming in, or when is my regular doctor coming in experience. So just a couple thoughts.
Those are really great. Thank you. Noelle, I see you have your hand raised too.
Yeah, Amber touched on them. I would just say I love the emphasize the belonging, like we're in this together kind of, and I think being vulnerable in being open about there's multiple slots overbooked, or if something else is going on, like another something that you have to manage, so that they understand. Because I think our learners are capable of that. And instead of hiding it from them and trying to shield them, I think being open about what's going on only helps them when they encounter that challenge later themselves.
Yeah, thank you. I agree. I think we all remember situations where we're working with someone as a learner and that person is stressed or overwhelmed, and we don't know if it's because of us or if it's in spite of us or what it is. So I agree. We tried to just highlight really a lot of all the really good tips that you all provided into some slides, just to use as a take home of how to approach these clinic situations where it can feel really overwhelming. I think about cardiology clinic, where even if a trainee sits in the wrong chair, it really could set up the rest of their day to be bad. So really just welcoming them to the clinic, starting out creating a culture of safety and openness, introducing yourself, teaching them that when they come in, it's important to introduce themselves to faculty, what their level of training is, and what they're hoping to get out of the day. Because I think then that really fosters a good communication with all the other clinicians in clinic as well. Asking them about their level of training and objectives, kind of like Andy said, and I think was echoed in all the comments. It's really important for learners to think about this before they enter clinic, because I think then it really gives them an opportunity and gives you an opportunity to give them feedback later in the day based on what their initial objectives is. And then whether it's, you want to set some goals with them. Sometimes it's listening to murmurs. Sometimes it's EKG reading. Sometimes we get into patients that are so complex, we have to take a step back and say, what are some things that I can teach on this to make this approachable? Because I've been taking care of this patient for 6 years, but this trainee is just meeting them today. And then asking them something about themselves on a personal level. I find it's really nice and easy to relate to trainees, especially when you find something in common. Clarifying their role. This is, I think, a big thing that can kind of help prevent passive aggressiveness in the education area of what exactly is their role in clinic, because then it's much easier to give feedback and assess their ability to live up to the role that you ask them to do. Based on their expectations and experience, it should be very clear whether you expect them to shadow initially. If you want to have them see patients and write notes, what note template do you want? When do you want it done? Should they be writing discharge instructions for you as you speak to a family? Talking about this ahead of seeing a patient really can help engage the learner in the clinical situation, ensure they're paying attention, and give you an ability to assess them later. Giving them ideas of how long they should spend in a room. And then I think especially trying to have some continuity if they're in an outpatient role, like we have them in our cardiology clinic, if they're going to be back tomorrow, showing them how to find the schedule for tomorrow and asking them to review patient charts ahead of clinic to try to set some goals. When time is tight, which feels like a lot of the time, I think we can just take little pearls to make learning applicable. So oftentimes it's trying to find what your learner's future career is and maybe talking about the type of antithrombotic agent that you're using in a patient with Fontan circulation, or the risk of infection in this patient population, to make it so that when they encounter one of these patients later on, they'll remember from that clinical situation with you. A lot of times, as I mentioned before, I try to just focus on initial disease presentation, especially for trainees that are entering a career in general pediatrics where they're picking a needle out of a haystack, to really help them understand what the patient's course has been like and how they initially presented to medical care, and then reviewing their diagnostic testing. I like to have a couple things that I can give them ahead of time. For example, if we're seeing a patient with hypertrophic cardiomyopathy, and there's a situation where a family might not be amenable to having a learner present, maybe they can take that time to read about hypertrophic cardiomyopathy. If it's a resident, to review the EKG and tell you how it looks different than the other EKGs. If it's a fellow, to review the most recent guidelines and tell you how they would manage that patient and what they would do at the next visit. And then having a couple canned learning topics, like things that are commonly encountered and relatively easy to do that you can teach in 3 to 5 minutes. Remaining engaged with your learners is a really big part of helping them feel like the environment is a good learning environment. Making eye contact as they present and not checking the schedule to see if the next patient's checked in. Being really mindful not to interrupt them and allow them to have their thought process. If you need to interrupt, using deliberate or artful questions to help them arrive at the assessment and plan. Asking for that assessment and plan and not just a rundown of what the patient's told you, and staying open-minded that maybe you can alter follow-up just a little bit based on what they suggested, or maybe you can consider a diagnostic text that you might not have, or even use that as an opportunity to explain why you wouldn't do that. And then continuity of care. To me, this is the most important thing in the outpatient setting that I think our residents probably have less exposure to, is how do we follow up with patients and how do we make sure care continues to be delivered when we're done with the encounter. I like to try to include them in messages about the patient. And if they're comfortable, I like to have them try to send those messages. For example, a patient with syncope, maybe sending a message to neurology if there was concern for seizure. Asking advanced trainees to review clinic ahead of time and make care plans, and then review that before the patients are seen. Maybe asking a trainee to call the PCP to summarize a plan, or how they would follow up. And then I think this is back to the point that was brought up in our discussion, is really making sure that you're admitting when you don't know something and using that as an opportunity for your trainee to teach you, maybe later in the week, or maybe touch base with them later in the week after you've had a chance to review something. If you encounter a challenging topic or situation, don't just ignore it. Take an opportunity to debrief and ask them how that made them feel and how they might encounter that differently. And engage even for a minute at the end of a clinical encounter in self-reflection, both for yourself and for your trainee. And with that, I'll leave it to Erin again to talk about inpatient teaching.
Perfect. And again, that's a great jumping off point too, as many of the outpatient things that from the literature and from Kirsten really apply to us as well. But just wanted to think about how this can be, applied on an inpatient rotation as well when you may have a bigger group and different pressures from a clinic. So I'm happy to read this, and I know a lot of my PHM colleagues are on. So we are thinking about ourselves as the inpatient attending or an inpatient subspecialty attending or anybody on a busy Monday, and you're meeting a whole new team. So you're meeting your senior resident, you have a children's intern, you have a visiting resident, you have an AI, you have 3 MS3 students. To start off with, let's say it's a light time of year, and so your rounding list has fewer patients. And then just kind of, I'll talk through some of our bullet points and then happy to pause for discussions. So how do you start and frame your day? Again, these are things that we may have done many times over the years, but just trying to think about the specific strategies and how we can carry those with us as time gets more crunched. What do you prioritize during rounds? How does this change if you have many new learners versus, it's later in the year and people are more experienced? Thinking about when you have a struggling learner as part of this large group, and then layering on all of that. Would love to hear how people think about this differently when as in a clinic is overbooked, your inpatient rounding morning is overbooked and there's a lot of people to round on. So lots of fruitful things for discussion. Appreciate if people want to type something in the chat, or I'm happy to mute and hear how you start to think about these different scenarios. Katie, thanks. Go ahead.
It's actually Sylvie who's going to be talking.
Hi, we're all in the conference room, really enjoying this presentation. So thank you for doing this. And I didn't want to say in the chat, but this is why we don't do outpatient clinics.
Yeah.
Sorry. Wah, wah.
We cannot contribute to that session.
But I would say that we start and frame our day the week before. So on Friday, you send that email to your team and you tell them your expectations, what your goals are for the week and what you want from them, which is you want them to identify their learning goals for you. So you already start hitting the ground running because you know then what your learners are looking for. And even though you have to take time to do your in-person icebreaker and make sure everyone knows what their roles are, it just really helps with the mental bandwidth that we all have on Monday morning to be able to get some of that work out of the way.
I think this is Katie Hayes. I think one thing that helps me on my Monday morning also is that we're lucky to do a week at a time. So I know that I don't have to accomplish everything in one day, which I think really helps. So I send the email the week before and then take that moment just to kind of set the team dynamic on a Monday. And then we'll set the expectation also that we will be learning together throughout the week. And then I know, I'm just thinking about what do you prioritize on rounds? If I'm being honest, I do my least, what you would qualify as teaching, where everyone would be like, this is clearly teaching. I do the least of that on Monday, but that's because I know I'm gonna have my feet under me and do better throughout the week. So I just use that time to set the expectations of here's what learning is gonna look like. Here's how I want you to participate. And I try to make it we're a team, ask questions, all that sort of stuff, so that they know that on the Monday when it's crazy, that's not what it's gonna necessarily be like all day, every day.
And I would say for the piece about how will this change if you have 14 patients to round on that Monday, right? As Sylvia said, I've already sent that out. If I only have 8 patients, I may take a little bit more time reflecting, opening opportunities for questions, getting to know them a little bit more in person because I have that time. That does get a little bit scrapped when I have 14 patients. And so my intro may be more of any major questions about what I've sent out. Please, feel free to reach out to me, and we're going to learn by doing today. And we need all hands on deck, and, similar to the clinic example too. So I do think having that flexibility with that intro allows me to stretch if I have time. And if I don't, then I really rely on that communication via email. So then we can move forward with patient care.
Thank you all so much. Thanks for thinking and joining. I'd just like to highlight something Amber said in the chat too. A lot of it, I think she was typing while and thinking while others were sharing. I think the expectations the week before, and then you kind of have more casual time for an icebreaker on the Monday morning is really nice. You may have already laid out your own priority for rounding, which allows people to get on the same page as you. And I think the other things that Amber wrote that are really, really nice and a little bit more of these like softer things are taking med students after rounds to show them the pantry, the equipment room, supply room, and where to find things. VRs may not know these things either. And then giving codes to the doors, again, just as you might orient someone to a brand new clinic and which chair to sit in, to be mindful that no matter how long we may have been, walking in these 7C workrooms, this is feeling different for our learners. And it's a really, really small and meaningful thing to kind of arm them with the tools to succeed for their week. And that is, yes, again, very, very good for medical students. So I'm happy to go through. We can certainly have a little more time of discussion at the end. There's a little bit of literature about how to create a good inpatient environment, many of which we've touched on, and they won't be shocking to you, but it's just nice to see that have all the different things that we're balancing and thinking about validated, I think. So what have trainees said that they want to have? Again, this is for inpatient specific literature, which are mostly like focus groups. They want to have sufficient time for bedside work, case review, and formulating their own plans. They want opportunities to observe and be observed performing core skills. Some of the core skills that inpatient, this is in the IM and PEDS literature, have mentioned obtaining consent for procedures or blood, breaking bad news, conducting physical exams, and then collaborating with the multidisciplinary team members. Interestingly, in some of these different articles, learners feel that the most valuable learning occurs on the wards, with didactics serving as a supplement. And I think that, you cannot have one without the other. So the combination is really powerful. And that is a really interesting piece of feedback. Lots and lots of focus groups. Again, what are things, switching to what exemplary attendings or clinician educators can do to create these environments for our learners. They put these into 3 different categories, and I'll go a little bit more into each of them. So number 1, they fostered positive relationships with all team members. Many are things that you all mentioned in our discussion, by building rapport, which really starts off and creates a safe learning environment. Hopefully Dr. Reese would agree. And then they facilitate patient-centered teaching points, modeling, in the room when you're the one examining the kid on family-centered rounds, your excellent clinical exam and communication techniques when applicable, and treating patients as partners, patients and families in the pediatric world as partners in their care. And then what are their teaching strategies? They're engaging in coaching and collaboration through facilitating discussion, effective questioning strategies, and then they're differentiating these different learner levels, but in a very open and welcoming way. This is a non-exhaustive list. These are just some of my favorite things from the different focus groups and just from my own experience. So using learners' first names, again, writing down whatever technique you need to do to memorize those names when you're meeting a lot of people, showing, as we discussed, showing interest in their well-being and their personal lives, responding thoughtfully to learner input, listening to letting them finish those questions and giving your answers. And then having that nice learning environment where there's questions asked, you're admitting uncertainty. You want to set high expectations for your learners, and that can certainly be in your email beforehand and about how you support them and ask them throughout the week, but you want to support the learners to reach those high expectations. You want to be able to giving appropriate, encouraging feedback along the week too, as well as encouraging your learners to question their superiors, because that is very, very important. Patient-centered teaching, again, they want their clinician educators to know the patient information well, to focus on the holistic patient needs that they have, to greet patients by name or ask the parents' names. They may watch you modeling if that's where you get to in the room for rounds. This could certainly also be what interns or residents or great medical students do. Thinking on what the patients or the families are sharing and adding that into your plan, which I think family-centered rounds also really encourages. And then again, one important, you are really going to be modeling being a compassionate clinician. Then again, what are your education strategies for this, and this fits into this adult learning. You're not going to be constantly lecturing. You're going to be involving your learners. You're going to use lots of question techniques to facilitate this thinking. You'll use questions to offer second thoughts without second guessing. Emphasize the thinking process over the content knowledge. I really liked what Kirsten said in her part 2 about being open to having slight changes in plan. And I think that's a really key part of running these teams. And then again, you're going to make sure that you're thinking about these different learning levels and team roles and how you can support them as one of the team leaders. So happy to just kind of go through our summary and then leave our last couple moments if people have other thoughts or questions, things that we brought up that you agree with, want to steal, don't agree with otherwise. So our summary from our work together is that what our learners are asking for is this safe learning environment, and they want to be able to ask questions, explore decision-making, and get feedback. We know that this is difficult in a busy setting, and we also know that things aren't getting any less busy anytime soon. So one way to think about this is that orienting our learners through self-directed learning principles can help provide a framework for lifelong learning. And then within the setting of mutual respect, of which there are many, many lovely ways to support that, we want to encourage goal setting for them, autonomy, and patient ownership in this setting. And we would love to feel this happy that our talk is done and that our learners are using our strategies. And I'll read the comments in the chat now, but would love to hear if anyone has any closing thoughts. Or Kirsten, if you have anything else you wanted to add from the end bit.
No, that was beautiful, Erin. Happy to hear what our audience has to say or what questions they have.
That was amazing.